Good afternoon, everyone. Bienvenue à ce webinaire de l'Institut de la recherche pour la science, la société et la politique publique. Cet événement aura lieu en anglais, mais si jamais vous avez des questions en français, soyez-vous bien à l'aise de les poser dans la langue de votre choix. So I'm Monica Gattinger. I'm director of the Institute for Science, Society, and Policy. It gives me great pleasure to welcome you to this first Food for Thought session of the year. So we undertake these sessions to profile the work and research of our members, and we're just delighted to have you with us this afternoon. So I'd like to begin by acknowledging that the land on which the University of Ottawa sits is the unceded territory of the Algonquin people, and I would encourage everyone to acknowledge the land on which they sit wherever you are joining us from. So just a few words before we get started. So as I mentioned, this Food for Thought series is about profiling the work of our members. Many of our members are working on issues related to COVID-19 right now, so we're just delighted to have with us Roxana Ahmed, who has been doing some very fascinating and pivotal work in this area. And the purpose of this session is to give her an opportunity to share this work and you an opportunity to learn more about it. We're delighted to have as our moderator today, Professor Dan Pare from the School of Communication. And both Dan and Roxana are members of a research team at the Institute for Science, Society, and Policy called At Risk. This is a project that focuses on how to strengthen risk governance in Canada, particularly on issues where there are differences of opinion or different perspectives around risk between experts and members of the lay public from a variety of different perspectives. So I think you'll see the session today will be related to that at some level. We're currently working, so a very small shameless plug for that project. We're currently working on developing a co-edited volume for the At-Risk project. It is in the process of publication right now, so we'll keep you abreast when that becomes available. It's going to be addressing these issues across a whole host of sectors. So before passing things to Dan, I wanted to just let you know as well that we have with us today Dr. Marissa Beck, who is the research director at the Institute for Science, Society, and Policy. She will be giving some closing words to the session and letting you know what's coming up in the Food for Thought series. So without further ado, I'm going to pass you to my colleague and friend, Dan Pare, Associate Professor at the School of Communication here at the University of Ottawa, and also a core member at the ISSP. Dan, the floor is yours.
Thank you very much. Thank you, Monica. Thank you, Marissa. Welcome, everybody. It's a real joy to be here today at this first session of the Food for Thought of the year. And for me, I'm especially delighted because I get to connect again with a former colleague from the Department of Communication at the University of Ottawa, Professor Roxana Ahmed. Roxana, when she left the University of Ottawa, she joined the University of Albany Sunny in New York. She then moved on to become director of the Department of Communication at the University of Albany, which is no small feat. Roxana comes to us and comes to us now and at the ISSP as an expert in health communication. She's established quite a name for herself throughout North America and around the world for her expertise in the area of health communications. A lot of the work in more recent years focusing specifically on issues of minority health disparities within the domain of health. I'm absolutely delighted to have this chance to converse with you today, Roxana. And I really look forward to hearing to what you have to say. The floor is yours, as we say, or I guess the interwebs are yours, as we would say now.
Thank you very much, Dan. Good afternoon, everyone. It's a pleasure to get this opportunity from ISSB to have a conversation about minority health disparities in this platform. And I'm really excited for the chance to share this space. It almost feels like home, although virtually, because I've been at the University of Ottawa since 2007 to 2018. I'm still affiliated with the Department of Communication as an adjunct professor, and also ISSB. So let me share the screen and bring up my presentation. So the bits of information that I'll be presenting this afternoon is based on research I have been doing at the University of Albany with my colleagues as part of a funded project. So I will share more information about that at the end. So let me start by beginning with some background information on the immigration status in the US. So my talk about minority health disparity will be focusing mainly on the immigrant populations based in the states and more exclusively the state of United States and the state of New York. So the US foreign-born population reached a record of 44.9 million, which is estimated at 13.7% of the US population. And these stats are coming from the American Community Survey 2019. Whites make up 17% of the foreign-born population, while Blacks at 10% and Asians make up 27%. So 44% of the foreign-born are of Hispanic or Latino origin. So the share of naturalized citizens is 51.6%, while that of non-citizens is 48.4%. And there are an estimated 10.5 million unauthorized immigrants. So basically, this scenario tells us that it is of high importance that we pay attention to immigrant populations who are part of the minority population group in the States, and look at the health disparities that they have been facing. And the immigration experience, to begin with, can be part of social determinant of health. And other causes are also structural barriers. Among those social determinants of health, I will focus on the limited English proficient individuals, because limited English proficiency is oftentimes associated with low health literacy and digital literacy, and also having less education. And these LP populations tend to live in poverty, and then they tend to be of working age, yet participate in the labor force at a lower rate than English proficient counterparts. They also tend to have lack of access to health insurance, inadequate access to linguistically and culturally appropriate services, with limited or no access to public assistance. So obviously the fact that they have limited English proficiency leads to all of these other factors that puts them in a vulnerable position when it comes to accessing healthcare. Literature has also showed us that poor communication and cultural concordance in healthcare can lead to lack of access to preventive care, delays in, and also poor healthcare experiences and treatment outcomes for immigrant populations. And those will include delays in and misunderstanding of and denial of treatment, receipt of the wrong treatment and errors in diagnosis. Oftentimes, medical ethics can be compromised when care is provided to these population groups. because of that poor communication and lack of understanding and lack of access to culturally and linguistically appropriate services. Also, for many of these population groups, it might be costly and to undergo diagnostic tests. And because of lack of understanding, they also are vulnerable to unnecessary diagnostic tests. They find it difficult to obtain informed consent. Also, we have cases of malpractice, negligence, and legal liabilities. So all of these factors are actually heightened because of poor communication and cultural non-concordance in healthcare. Also, patients of immigrant background, when also with limited English proficiency, tend to have lower patient satisfaction. And all of these factors actually then eventually lead to higher healthcare costs. So I'm going to shift our focus to COVID-19 challenges for immigrants. Because of the social determinants of health and the structural barriers that I just highlighted, immigrant populations, those factors have actually heightened and disproportionately affected them, putting a burden when COVID-19 considerations are taken into account. These would include higher exposure to and rates of infections and lower test rates among these populations. Also, lack of linguistically and culturally appropriate information and services. And oftentimes that could lead to these population groups being more vulnerable to misinformation because they have lack of proper health literacy or digital literacy, and sifting through that information sources could be really challenging for them. Also, the housing and neighborhood context is of concern, and that puts them in a situation where they are not able to properly social distance. Also, in the case of the states, the documentation status is a concern. Oftentimes what happens is that if you take into account the use of emergency rooms, oftentimes that's restricted, and that is actually a source of care for a lot of undocumented immigrant population groups. So there's also this fear of being considered inadmissible, and that results in loss of access to benefits for this population group. And this is just to give you a glimpse of the disproportionate burden on the immigrant population in the States, and mainly focusing on, for this part, the foreign-born New Yorkers, because they experienced a disproportionate burden of unemployment and loss of income under COVID-19. But on this side, on the right side, this data is actually the national level, and you can see the unemployment rates in January 2020 and April 2020, so the beginning of the COVID-19 pandemic, and how the foreign-born women were compared, foreign-born men and native-born with native-born women and native-born men. So what to do to address this situation? We have to look into evidence-based interventions that can help us mitigate and manage and address and actually prevent these minority health disparities when, in this case, immigrant population groups are concerned. So literature has shown that the use of health navigators, community health workers, and home visiting programs could work, could become good practices So they would include, these would include culturally and linguistically competent and trained community health workers who are able to deliver information to clients and work with them and their families in the language that is appropriate, in the cultural manner that is more appropriate, and help them access services, including health prevention, health insurance enrollment, because if you remember in previous slides, I was showing how oftentimes because of not having the required level of language proficiency, the immigrant population groups, oftentimes members of those groups actually don't have the proper information to be more informed patients. And also educational tutoring is helpful, parental classes and home health assistance. So the health navigators, community health workers, and home visiting programs can help to facilitate these. Also, there is this program where trusted cultural brokers work with immigrant groups. So they deliver intervention through these trusted culture brokers who proactively reach out to and serve immigrants where they live. Because building that trust, if one thing we have noticed in the pandemic is that there is a lack of trust within the community with regard to public health systems. So, another important point is to look at community partnerships and coordination. So what happens is that this is part of more of a comprehensive approach to meeting the multiple health and non-health needs of immigrants. Cross-sector collaborations have been proven to be more successful. But they also, because they tend to be mutually beneficial and advance the capacity of all partners to advance their mission more effectively. So this could include academic and community partnership, also at the government level, and nonprofit organizations. So a successful example has been the Changing Culture Project. This project actually used partnerships between health, education, and resettlement sectors that allowed to respond to vocational issues facing refugee young people who used, and they used a mental health framework. So the project actually was able to provide language literacy and basic education while integrating workforce development and mental health. Then there is this consideration of linguistically and culturally responsive health organizations. Oops, sorry. So basically, it is argued that language access models could be integrated because it then allows leadership commitment to develop clear language access goals and measurable objectives. Also formal policies and protocols that can direct strategic planning and actions that can also help to set priorities and guide day-to-day activities. Also, communication and monitoring strategies can ensure staff understands and consistently implements them. Human resources policies can diversify staff to reflect the communities that are being served. Also, it includes trained interpreters who are proficient in the languages used, as well as in the medical terminologies, because oftentimes with immigrant members of immigrant population groups who suffer from basic literacy skills and also health literacy skills can benefit from these trained interpreters. Also, staff accountability through performance evaluations, language access and audits, quality improvement programs, and patient satisfaction surveys. All of these can be factored in with an integration of a language access model. Last point I want to highlight is proactive policies and programs. So come to think of it as proactive governance. So for example, if communication policy is concerned, then attention should be paid to written, verbal, proactive outreach when immigrant populations are concerned. Also having a vision statement for immigrant inclusion, so issues of diversity, equity, and inclusion, having strategies around those, incorporating language assistance in strategic plans, also administrative structure for settlement programs, collaborative governance, public consultation, and of course, recruitment and diversification of the public workforce. So basically, that's all I wanted to throw out there for a discussion. And I would like to acknowledge my co-PIs, Dr. Dana Refke, Department of Public Ed and Policy, and Dr. Jeanette Alteriba, Department of Psychology at the University at Albany SUNY. We have been, the three of us as an interdisciplinary team, have been working on COVID-19 focused projects looking at minority health disparities, including immigrant populations and especially population groups who are considered to have limited English proficiency. And our work has been supported by the UAlbany New York State COVID-19 Minority Health Disparity Initiative on behalf of Governor Andrew Cuomo. And we are part of the Engaged Researchers Group, 36 to 40 researchers at UAlbany, working on the project under the broader umbrella of the project Differential Impacts of COVID-19 in New York State, Understanding and Eliminating Minority Health Disparities in a 21st Century Pandemic. Thank you.
Thank you very much, Roxana. We finished a little bit ahead of schedule, which is good. That allows more time for some questions and answers. With that in mind, I think perhaps I don't see any questions just yet online. I'll take the liberty of perhaps starting the discussion and asking you a question myself. I'm wondering if throughout your slides you spoke about, the common theme was evidence-based interventions. And I'm wondering if you could just speak a little bit to provide some details and elaborations on specific types of interventions to which you're alluding to, what those look like, and the sorts of shape that take place, and perhaps even some of the participatory elements in terms of what role do community members, the affected populations that you're dealing with, what role do they have, what contributions do they make in actually engaging and shaping the parameters and context and contours of types of interventions that you're speaking of?
Yes, of course. Thank you for asking that question, Dan, and for seeking clarification. So basically the few interventions that I mentioned and the basic approach has been around structural interventions. So not at the individual level. And you rightly pointed out, basically these interventions have been proven effective because they had a community, a CBO type of approach. So the CBOs are the one model for engaged research, community-based organizations, because they help to establish important links to community members. So it becomes almost like a participatory approach. Because these interventions have been focused on immigrant population groups, and because they have unique linguistic and cultural needs, having to include the community makes a difference, because then you can work with opinion leaders who can take the information, be trained, and then take the information down to the community and actually help address that gap where oftentimes, you see in most cases, interventions that fail for certain communities, it's because they tend to have a more top-down approach as opposed to a bottom-up where from the very beginning of the intervention, invite and include the community members who are being directly affected by the problem. So integrate them into the design of the project, design of the intervention, and then also include them to help carry it out, implement, and not only that, include them in the evaluation of the program as well.
Okay. While we wait for some other questions, I'll take the liberty of asking one other question, which has to do with your experience specifically. I mean, having spent a number of years working broadly in this area within the Canadian context and quite some time within the context of the United States, in terms of these sorts of interventions and working in areas of trying to address disparities in the areas of minority health, what are sort of I wonder if you can comment on sort of perhaps some of the major points of convergence and divergence between the Canadian context and the US context.
Yes, thank you for that question. So as I said at the beginning, that this work has been focused on the US context. And you rightly pointed out that I have had years of experience and actually current projects that are looking to the Canadian context. And as far as COVID-19 health disparities are concerned, specifically focusing on a refugee population group. So when immigrant communities are concerned, one very glaring difference that we see, I notice in the, that's been documented in the literature and also through my field experience, has been the documentation status. Policies at the federal level in the US context have been detrimental to immigrants who do not have documentation status. So sometimes, we have seen that these policies have exacerbated the distrust and fear of government authorities and have complicated access to health and public benefits. So oftentimes you see that. So, we have unique characteristics when it comes to immigration policy. And when you compare that between the US and Canada. So for example, in the case of the US, the Affordable Care Act basically excludes undocumented immigrants from health insurance coverage. So that is actually a big concern. And with COVID-19 making emergency room visits restricted, there is no alternative since undocumented immigrants normally do not have access to primary care providers, as opposed to in Canada, we have the, through OHIP, I'm talking because my experience has been in Ottawa, the access to medical care when needed for the immigrant population groups. Yeah.
Okay. We have 3 questions that they broadly overlap, I think. So the first question that we've had asked about the Biden administration. The new Biden administration is bringing in policies to ramp up the fight against COVID. At the same time, they're starting to seek to tackle equity issues. So the question becomes, is there something the US federal government could now be doing to address some of the problems that you've identified?
Thank you for this question. I am not in a position to comment on that, but certainly since in relation to the talk that I've given, I've highlighted structural interventions. And obviously that has to, and I also talked about proactive governance. So I'm sure it's not only me, but my colleagues and researchers and community organizations who serve, for researchers who focus on minority health disparities and immigrant service providers, would hope that we would see a vision statement for immigrant inclusion, and then better coordination between advisory and council bodies, administrative structure for resettlement programs, all of this. So basically a proactive governance that would help facilitate addressing minority health disparity issues under the Biden administration. So that's all I can say in relation to the topic I covered and the position I hold.
Okay, very good. Thank you. Thank you. The second question we have pertains to the types of disparities that minority populations are suffering or experiencing from, right? And the question basically is it your view that minority populations are pretty much all suffering from the same types of disparities? And related to that, the second part of that question is, how are the sorts of interventions of which you've mentioned transferable amongst different minority populations?
So oftentimes, we see that the immigrant experience can be driven by the social determinants of health that I pointed out. And some of these include lack of language proficiency, living in poverty, a lower socioeconomic status, the immigration status, so the documentation status that I talked about, and then overall a lack of access to resources. And so oftentimes these social determinants of health are more prominent for newcomers, just like what we see in Canada too. So this immigrant experience, immigration, led vulnerabilities tend to be a kind of similar experience for different immigrant communities, across different immigrant communities, but also we should not forget that there are unique needs when it comes to individual immigrant communities. So oftentimes it has to do with members of immigrant communities who are coming from XYZ countries, so with certain backgrounds, because oftentimes certain countries tend to have higher literacy level. Probably oftentimes certain immigrants from certain countries had more knowledge about, and proficient in certain languages, for example, English. Oftentimes, it depends on the country, country of the member of the immigrant community, and their status in terms of not just educational background, but also assets. So the socioeconomic status that they used to have back home, whether they came on certain programs with certain skills already, and that could be related to their education, their skills that could match with the jobs that they are looking for in the host countries. So all of these factors could play a role in terms of leading to unique needs for immigrant communities across the immigrant population group. So I think this one part of the question, and I can take a look at the Q&A too, that how are these interventions transferable to other minority populations? Is that correct, Dran? And I guess there was this Arab immigrants. So And I can focus on the language component when it comes to limited English proficient immigrants in the States, because many healthcare facilities, and this is not just unique, unfortunately, this is not just unique to the case of the States, United States, it's also, I guess, the reality to many extent in the case of Canada, when healthcare facilities lack a formal language assistance system. And as we know, in Canada, we have 2 official languages, so it's not just English, but it's also French too. So in the case when healthcare facilities lack a formal language assistance system that is not integrated in all operating systems, it actually poses problem. And I can tell you that an intervention at the structural level that allows for formal language assistance system integrated into all operating systems could actually help to set formal policies for language assistance, set formal protocols for identifying preferred languages, and that could be based on the limited English or French proficient status and health literacy status. That would also allow to collect, record, and use data on preferred language. Also train staff to develop cultural competency. Also would allow hiring staff who reflect the linguistic and ethnic makeup of the communities they serve. Accesses also trained and professional medical interpreters in a timely and efficient manner. Also would allow translating vital documents, including informed consent, into patients' languages. Because if you remember in my talk, I was referring how the lack of the required proficiency in the required language oftentimes actually poses a barrier when it comes to immigrant population groups and patients. And when they seek healthcare and the lack of informed consent, and it happens, it's not just that they are not interested and they're not aware and not concerned about their health, they actually don't understand what's written on the paper. So it comes to that basic level of understanding. Also, monitoring and evaluating language assistance programs could be transferable when it comes to any immigrant population group, members of which suffer from limited English proficiency or in the required language that community is living under.
Thank you. Thank you. Our third question asks in a way that we cast our eyes forward a few months ahead. And it has to do in terms of thinking about the research in your presentations. What are some of the implications of your research in terms of when a COVID vaccine supply becomes much more available and pervasive throughout our countries? And so the question really is sort of, what are some of the key practical barriers to the uptake of vaccines that you see and possible solutions to consider in light of the work that you're doing?
So I will, that's a very pertinent question. I will go back to this idea of the importance of having linguistically and culturally responsive healthcare organizations administering these, because we have seen that trust in the public health system has really gone down. It had always been an issue for certain communities, especially we know for Black communities in the US. And historically, the Tuskegee syphilis case is always cited. And then there are other immigrant minority population groups who for various reasons, especially for immigrants, the documentation status becomes one. We see a lack of trust and lack of coordinated efforts. When it comes to minority population groups who have unique linguistic and cultural needs, a linguistically and culturally responsive either community health organization or even at the government level would be important because then, we can be sure of having leadership commitment to develop clear language around these issues. We can also see formal policies and protocols that would help to direct strategic planning and action, because we see we have seen a lack of coordinated effort. And also when it comes to the issue of vaccine hesitancy, establishing that trust with these communities where this lack of trust is more prominent would be important, and working with trained and trusted cultural brokers would be really important. So again, going back to the idea of identifying the opinion leaders in a community. And these opinion leaders could be a religious leader. It could be a business leader in a community who people go up to, look up to, and go to for advice. Faith-based leaders in faith-based communities would be important. So you really have to know the community you're targeting, know their makeup, know their communicative practices. Oftentimes it's also the language that they speak in. It's not just literal language, but the speech community. Who do they trust? How do they communicate? Those will be important considerations, and work with members of those communities, those opinion leaders, to reach out to people who are in need of this care. That would be important.
Okay, before we go to the fourth question, just building on your last comments there, when you're talking about sort of opinion leaders and community leaders and cultural brokers and such, I'm wondering, the one thing that you didn't touch upon, I don't know if it was deliberate or not, but was celebrities.
Oh, yes.
And I know in the UK, there's a context in terms of now we're seeing a lot of celebrities from different immigrant communities and linguistic communities and such who are now as part of a government advertising campaign to try and minimize vaccine hesitancy within the UK context, have taken to the airwaves. And I'm just wondering, in terms of how or if you see celebrities fitting into this picture.
Thank you, Dan, for pointing that out. No, of course, celebrities have been historically identified as important members of the opinion leader group. And we have seen that with polio vaccine eradication efforts, interventions. It's interesting because maybe it was subconsciously that I did not mention celebrities, because every time this topic comes up, I cannot help but think of the Jenny McCarthy effect with measles and all that, vaccination and the connection between autism and whatnot, because they could also unfortunately have a negative impact. So I guess that's why having a coordinated effort would be important when opinion leaders are concerned. So if it's a community, if it's where a given celebrity is more popular, so there has to be program planners, campaign programs would actually have to do much research into finding these, because they could backfire for XYZ reason. It also depends on the population makeup. So your target population makeup, so you have to know, you have to do research about not only about their beliefs and worldviews, but also their source of information. So when it comes to, even if celebrities are concerned, their pop culture consumption habits, and who do they look up to? It could be a singer, it could be an actor slash activist. So it really depends, but careful research and considerations would be required. Thank you.
Very good. Thank you. Your comments actually segue us very nicely into the fourth question that we have, and particularly your comments around pop culture consumption and the possibilities for negative impact of celebrity endorsements of different positions, and specifically in this case, in terms of our fourth question, the issue of social media and disinformation, and much of the information that we're hearing, of course, in terms of social media as platforms for disseminating so much disinformation and misinformation. The question that we have was, could you please elaborate on how misinformation is being propagated within some of the communities to which you're referring in your presentation today?
Yes, thank you. And I think at one point in my talk, I was referring to the lack of access to linguistically and culturally appropriate information, excuse me, and how that could make members of minority communities more vulnerable, susceptible to misinformation. So it will be important to look into information channels, their information pathways, information seeking pathways. So for example, in our current day society, we know that social media use has become a social determinant of health. So targeting populations using these channels would be important, as well as looking at ambassadors. So going back to the idea of opinion leaders, who do they follow on Twitter, for example, as an example of a social media channel. And oftentimes, we know that fortunately or unfortunately, it depends in which context you're asking this question, that could be the only source of information for many of these folks. So when it comes to information as important and sensitive as health, who do they trust to evaluate the information they get? That becomes really important. And these are some, it's actually interesting because this question, and which led me to share this information, became part of a 3-campus community conversation we just had over the past 3 weeks at UAlbany. And in our small group, which focused on multi-level services and interventions, we actually discussed this issue. We talked about minority communities becoming more susceptible to issues of misinformation and disinformation. And we talked about the importance of actually targeting research to these issues. And the other important component I would highlight is the importance of science education, science communication, and that has also been a topic of discussion for the 3-campus community conversation, but it also is something that I've been involved with, part of a project on sharing health information with folks from Vancouver and Ottawa, actually. So communicating health research has become really important because in the rush of COVID-19 information, we have seen a lot of rapid research, rapid expedited review processes. And so it's not that, okay, we're looking at a a vast majority of people, minority, who belong to the minority community, and probably not everyone looks up to social media for their sources of information. They could be also reading blogs, online articles, open access, and all of these have also made, all of these different platforms have made the importance of science communication more prominent, and science education too. So we have seen the use of hyperlinks, and you click on the link and you go to a source, probably not thinking that these are credible sources. And a lot of us actually oftentimes think that, oh, it has been a quoted source, cited source, so it's credible. But we need to question where this information is coming from, who is producing this information. So that whole idea of information literacy, media literacy. But it also this rush for unverified information in the form of, when it comes to communicating health research, preprints, the use of preprints, which are basically part of our research group. The new publication that we have, we talked about this, that it's unverified science. So it will be important for health journalists also to be trained in these. And if that health journalist or communicator or even public health officials, if they're gathering information from these sources, to know what they're looking at. So they need to be educated first themselves. And then if they want to train the opinion leaders, the community ambassadors on the importance of trustworthy information, so that they can take that information down to the community who probably are looking up to them or who probably trust them.
Thank you very much for that. I don't see that we have any more questions, so we're just a couple minutes ahead of schedule. But I want to thank you very much for this really insightful and fascinating discussion today. Definitely with tremendous implications going forward, certainly in these trying times of COVID. So with that, I thank you. And I believe we have the ISSP's research director is going to say a few words. So informally, Roxana, it was lovely chatting with you again today. Great. Okay.
Thank you so much, Dan. Same here.
Thank you. Yes, hello, my name is Marisa Beck. I'm the research director of the ISSP, and I just wanted to quickly use this opportunity to thank all of you for attending today's Food for Thought event. And also many thanks to Roxana Amit and Dan Paré for a really insightful and thought-provoking conversation on a very current and important topic. Finally, I would like to thank the entire ISSP team, especially Brendan Frank and Raphael Desordis, for making this event happen today. Thanks to you all. And just on a final note, if you like today's webinar, the Food for Thought event series is actually monthly. So we have the monthly lunch talks, and it is happening, those events are happening every last Thursday of the month. So on February 25th, the next one, we'll actually host another event focused on the current COVID-19 pandemic. And we are very excited to welcome Stacy Smith, a professor in the Department of Mathematics and the Faculty of Medicine at the University of Ottawa, who will speak about how COVID-19 modeling of potential outcomes on campus helped the University of Ottawa with decision-making about how to respond to the pandemic. And the moderator for that session will be Jacob Berkowitz, who's one of our writers in residence here at the ISSP. So we hope we can welcome you again on February 25th. And please sign up for our newsletter or follow us on social media to always be informed about upcoming ISSP events. Thanks to you for attending, and thanks to our amazing speakers and the ISSP team, and goodbye. We hope to see you again soon.